Fiber tenderness in the over the right costovertebral angle. Does she has pyelonephritis? Our mistakes are so similar. Okay, this patient has acute pyelonephritis. This patient has acute pyelonephritis and upper urinary tract infection. Pyelonephritis is more common in the pregnancy, likely due to an increased risk for recurrent asymptomatic bacteriuria, physiologic maternal immunosuppression, in addition progesterone-induced uterine dilatation, uteral valve laxity, and bladder compression from the gravid uterus. Bladder compression from the gravid uterus may facilitate bacterial ascent from the lower urinary tract. Patient with pyelonephritis can have preceding symptoms of cystitis, dysuria followed by fever, chills, back pain, maternal and fetal tachycardia, costovertebral ankle tenderness. Diagnosis is confirmed by urine analysis and leukocytosis blood. As in seen, this patient urine culture is also performed. Pregnant patients with pyelonephritis are at high risk of severe maternal sepsis, acute respiratory distress syndrome, preterm labor, and fetal, like preterm birth complications. Therefore, those patients require inpatient admission and empiric intravenous antibiotic ceftriaxone while urine culture results are pending. Once patients remain afebrile for 24 to 48 hours, have symptomatic improvement, they may be transmitted to the oral antibiotic culture based on urine culture results and antibiotic sensitivity testing. Yes, abdominal and renal imaging CT scan of the abdomen and pelvis renal ultrasonography can be used to diagnose nephrolithiasis, which may also present with radiating back pain and hematuria. However, these patients fever and history of pyelonephritis make acute pyelonephritis more likely. Imaging is not required for diagnosis in patients with classic clinical point. Imaging in pregnant women typically reveals physiologic hydronephrosis that could be mistaken for pathology. Physiologic hydronephrosis that can be mistaken for pathology and lead to unnecessary intervention, ureteral stent placement. Therefore, imaging is reserved for patients whose condition does not improve within 48 to 72 hours of IV antibiotics. In this patient, renal ultrasound is performed to evaluate nephrolithiasis, which, if limited to small distal ureteral calculi, can be treated with IV fluid and tamsulosin, or renal abscess, which typically require drainage. Okay. Okay. Pregnancy is associated with increased risk of influenza associated morbidity. Pregnancy is associated with increased risk of influenza associated morbidity and mortality, pneumonia, acute respiratory distress syndrome. Therefore, all pregnant women without contraindication should receive inactivated influenza vaccination as soon as it becomes available. The inactivated influenza vaccine is safe during every trimester of pregnancy and while breastfeeding. The live attenuated intranasal vaccine is contraindicated during pregnancy due to increased risk of congenital infection but is safe during breastfeeding. In addition, preventing influenza in mother also preventing influenza in the mother vaccination also provide passive neonatal immunity and has been shown to decrease the frequency and severity of influenza in newborn. High. post. It is in between B and D, written product or vaginal hematoma. Sorry, B and D. Sorry, not B and D. It is not von Willebrand disease. Okay, okay. But PTT is normal. Okay, I was wrong. Okay, it's inherited. It is inherited coagulopathy. Okay, this patient PPH, postpartum hemorrhage, and a prolonged bleeding time, but otherwise normal coagulation study. Prolonged bleeding time, but otherwise normal coagulation study likely has von Willebrand disease. Von Willebrand disease is a common coagulopathy that is due to quantitative or qualitative von Willebrand factor deficiency. It usually presents with mucocutaneous bleeding, epistaxis, gingival bleeding, and is a common cause of secondary or late postpartum hemorrhage. Von Willebrand factor assists in platelet adhesion and aggregation. Platelet adhesion and aggregation acts as a carrier of factor 8. Factor 8 is more rapidly degraded when unbound, and von Willebrand factor deficiency can therefore lead to impairment of the intrinsic coagulation pathway, sometimes leading to a prolonged PTT. However, patient can have normal APTT for the patient can have normal APTT for the following reasons. Patient with mild to moderate von Willebrand factor deficiency. Patient with mild to moderate von Willebrand factor deficiency may have adequate factor 8 levels to maintain APTT with normal range. Von Willebrand factor and factor 8 are acute phase reactant, and inflammation and stress can acutely raise levels. Von Willebrand factor synthesis is increased by estrogen and thyroid hormone. Pregnancy, OCP, and thyroid replacement can raise von Willebrand factor level and normalizes APTT. Okay, that's why APTT is normal. Like pregnancy raises von Willebrand factor level and normalizes APTT, but it cannot change the bleeding time. Okay, platelet count and PT are normal in von Willebrand factor disease, but platelet function impaired platelet function causes prolonged bleeding time. Diagnostic studies include von Willebrand factor antigen level, von Willebrand factor activity, ristocetin cofactor activity, and factor 8 level. Desmopress DDAVP potentiate the release of von Willebrand factor from the endothelial cell and can be used in the management of acute bleeding or for prophylaxis Okay. Yeah. Okay. She has preeclampsia, isn't it? So complication of preeclampsia. It is either A or D.
Yes.
Oh, okay. I missed. Okay. This patient with new onset epigastric pain, hypertension, proteinuria. This patient with new onset epigastric pain, hypertension, and proteinuria, 37 weeks of gestation, has preeclampsia with severe features. Preeclampsia with severe features, potentially life-threatening condition. Preeclampsia is most likely caused by abnormal placentation and narrowed spiral artery formation. The resulting placental hypoperfusion, hypoxia, and ischemia trigger the release of anti-angiogenic factor causing maternal endothelial cell damage. The damage may manifest in multiple organ systems including the liver, referred epigastric pain from stretching of the hepatic capsule and kidneys, proteinuria from acute kidney injury. In the brain, endothelial cell damage can precipitate an acute stroke. In the brain, endothelial cell damage can precipitate an acute stroke via following mechanism: activation of the coagulation system, placental activation of the coagulation system, platelet aggregation, and vascular microthrombi formation leading to cerebral vessel occlusion, ischemic stroke, flow, dysregulated cerebral blood flow that causes inappropriate cerebral vasospasm, severely elevated perfusion pressure, and rupture intracerebral vessels, hemorrhagic stroke. So ischemic stroke can happen, hemorrhagic stroke can happen. To decrease the risk of to decrease the risk, patients with severe range hypertension, systolic more than 160, diastolic more than 110, require prompt antihypertensive therapy, IV labetalol, IV hydralazine. Treatment of preeclampsia with severe seizures. Treatment with preeclampsia with severe seizures. Sorry, treatment of preeclampsia with severe features is delivery, because removal of the placenta is typically curative. Okay. fetal breech presentation. Is it smoking?
No.
It is either B or D.
B, B as in boy or B as in
Okay. Okay. Breech presentation. Breech presentation occurs when the buttocks. Breech presentation when the buttocks are felt. When the butt sorry, breech presentation occurs when the buttocks or feet are the fetal part closest to the maternal cervix. It is common type of fetal malpresentation, has an increased risk of complication during vaginal delivery trauma, umbilical cord prolapse, head entrapment. Variable fetal presentation including breech is normal during early pregnancy due to small fetal size relative to amniotic fluid volume. With increasing gestational age, particularly at term gestation, the fetus typically develops cephalic presentation and thereby optimizing chances of an uncomplicated vaginal delivery. Fetal malpresentation breach can occur when either fetal mobility or maternal anatomy fixation of the presenting part in the pelvic inlet is affected. The common risk factor for breech presentation as it's seen in this patient is uterine leiomyoma, particularly submucosal fibroid because they can distort the uterine cavity and limit fetal mobility. In addition, uterine leiomyoma, in addition, in addition, large leiomyoma in the lower uterine segment can become space occupying and prevent fetal cephalic engagement. Patients with breech presentation and no contraindication to vaginal delivery, placental previa prior cesarean delivery can be offered an external cephalic version, manual rotation of the fetus to cephalic presentation more than 37 weeks of gestation. Okay, in the box, look at the box. I'm reading the risk factors mainly. This is important. Advanced maternal age, uterine didelphus, receptive uterus, uterine leiomyoma, as in this patient, fetal anomalies, anencephaly, preterm, less than 37 weeks of gestation, oligohydramnios or polyhydramnios, and placenta previa. And for breech, we should do ECV, external cephalic version, and cesarean delivery. Is it Shihan? Okay. So this patient's postpartum hemorrhage with uh, this patient postpartum hemorrhage with subsequent lactational failure, hypotension and fatigue is concerning for Sheehan syndrome pituitary infarction. During pregnancy, the pituitary gland enlarges because high estrogen level induce lactotrop hyperplasia. However, because blood supply does not increase proportionally, the anterior pituitary becomes vulnerable to ischemia from hemorrhagic shock. Therefore, the classic presentation of Sheehan syndrome occurs following massive postpartum hemorrhage. The resultant pituitary ischemia causes panhypopituitarism and deficiency of the hormones of the anterior pituitary gland, resulting in constellation of the symptom. Prolactin deficiency can cause lactation failure, ACTH deficiency can cause fatigue, hypotension, anorexia, weight loss from ACTH, and subsequent cortisol deficiency. Secondary adrenal insufficiency, gonadotropin deficiency can cause amenorrhea, and TSH deficiency, fatigue, bradycardia can cause central hypothyroidism. Patients with suspected Sheehan syndrome require hormone level like cortisol, FSH, prolactin to confirm the deficiencies and guide management for hormone replacement. No, in HELP there is anemia, thrombocytopenia, and uh, elevated liver enzyme, but there is high leukocyte. Leukocyte count is higher. Yes, no, looks like there. I think that like in here, acute. Sorry, it may be acute fatty liver of the pregnancy. Bilirubin is high. There is glucose. Look at the glucose. Glucose is low. So, Yes, acute fatty liver of the pregnancy has only one treatment. You can guess. No, no, protein. Why protein? 24-hour protein for preeclampsia. We are not thinking about that thing. Okay. Look, in here the what can I say? Liver function test is not that scary, but as she's pregnant, so that much high liver function is scary. And acute fatty liver of pregnancy has only one treatment actually, so nothing to remember in here. Okay, but its diagnosis is critical, confusing actually. Yes, this patient has acute fatty liver of the pregnancy, a rare but life-threatening condition. If we tell any patient in our country that she has acute fatty liver of the pregnancy and she need immediate delivery, that lady will rush to the doctor and try to kill her. So uh, there is another problem. Like I'm just talking as because when there is as the information is available in everywhere, so everyone is a doctor, so everyone can go through this and that, and they start thinking about that they are right. That is scary part in our country. So this patient has acute fatty liver of the pregnancy, a rare but life-threatening condition that develops in the third trimester, particularly in patients with multiple gestation. Acute fatty liver of the pregnancy is an intrinsic hepatic disease likely due to defective maternal or fetal fatty acid metabolism. It can cause hepatic inflammation, epigastric right upper quadrant pain, leukocytosis, elevated transaminase, and subsequent fulminant liver failure, sclerosing hyperbilirubinemia, and prolonged hypoglycemia. Acute fatty liver of the pregnancy progresses. Patient can develop multi-organ failure, including DIC, hemolytic anemia, thrombocytopenia, and acute kidney injury from hepatorenal syndrome. As the mother decompensated, the placenta hypoperfuses, which can result in fetal hypoxemia, acidosis, and subsequent death due to high maternal fetal and high maternal and fetal mortality. Management of acute fatty liver of the pregnancy is maternal stabilization and immediate delivery regardless of the gestational age. Yes, yes. A 24-hour urine protein test evaluates preeclampsia with severe feature which may also present in the third trimester with uh, right upper quadrant pain and signs of end organ damage, elevated creatinine. This patient does not have hypertension, systolic more than 140 and diastolic more than 90, making the diagnosis less likely. Emergency cholecystectomy is performed for complicated acute cholecystitis, gallbladder perforation, or gangrene, which may present with postprandial right upper quadrant pain and an elevated ALP level. Acute cholecystitis does not cause hyperbilirubinemia and profound hypoglycemia. In addition, the source of this patient's elevated ALP level is likely the placenta. And yes, you want me to read the D&E also? D&E is not okay. she is not on, she is HIV positive, she is on, she is not on antiretroviral therapy, isn't it? Okay, so if she is taking, if she was taking before, then we can think about the vaginal delivery. As she is not taking, so now, so no chance of vaginal delivery. Maybe. Okay. Cesarean delivery. Okay, I'm reading the box later. Okay, this patient at 37 weeks of gestation with regular contraction, cervical dilatation, and a category 1 fetal heart rate tracing in, is in early normal level, which is typically managed expectantly. However, labor management in patients with HIV differs from on maternal viral load at delivery, which determines the risk of vertical transmission to the neonate. Patients with HIV viral, patient with viral load less than 50 copies, patient with viral load less than 50 copies daily can deliver vaginally because the risk of vertical transmission is low. These patients do not require additional interpartum antiretroviral therapy but do continue their daily antiretroviral regimen. Patients viral load more than 50 copies but less than 1000 copies are at a slightly increased risk of vertical transmission and often receive intrapartum zidovudine along with their daily antiretroviral medication. However, vaginal delivery is still acceptable because transmission risk is not further reduced. Transmission risk is not further reduced by cesarean delivery. In contrast, patients viral load more than 1000 copy and high risk of vertical transmission during delivery. The fetus is expected to infected maternal body fluid during passage through the vaginal canal and is skin greater risk of skin barrier compromise. Caesarean delivery reduces the perinatal HIV transmission by 50% when maternal viral load is more than 1000 copies. Therefore, along with administration of intrapartum zidovudine, which can also reduce the vertical transmission rate, the best next step in this patient management is caesarean delivery. The patient also should adhere to her daily antiretroviral regimen. Okay. Okay. In antepartum testing of HIV, one viral load monthly until detectable, then every 3 months. CD4 count should be done every 3 months. Resistance testing if not previously performed. Initiation and or continuation of the heart. Avoidance of amniocentesis if viral load is detectable. And intrapartum avoidance of artificial rupture of membrane, fetal scalp electrode, operative vaginal delivery. Interpartum viral load less than 50 copies and antiretroviral therapy plus vaginal delivery. Viral load more than 50 copy but less than 1000 copy antiretroviral therapy plus with or without zidovudine plus vaginal delivery can be done, and viral load more than 1000 copies antiretroviral therapy plus zidovudine plus cesarean section. Okay. Okay, the Rh blood group is composed of 5 antigens that induce antibody formation. The most common antigen involved in fetal and neonatal disease, the D antigen. Rh D antigen alloimmunization sensitization occurs when Rh positive, Rhd positive fetal erythrocytes enter the bloodstream of an Rhd negative pregnant woman who develops antibodies against the D antigen present on fetal erythrocyte. Although the anti-D antibodies do not affect the fetus of the first pregnancy, these antibodies are destructive in subsequent pregnancy. If the alloimmunized woman has a subsequent pregnancy with Rh positive fetus, her anti-D antibodies will bind and lyse the fetal erythrocytes. Therefore, these unsensitized Rhd negative pregnant women should receive anti-D immunoglobulin ROGAM to lower her risk for alloimmunization and the development of hemolytic disease of the newborn hydrops fetalis in subsequent pregnancy. The placenta is a barrier between the pregnant woman and fetus, but fetal erythrocyte may enter the woman's circulation during abortion procedures like amniocentesis or delivery. Anti-D immunoglobulin is administered at these critical times and binds the D antigen on the fetal erythrocytes in the pregnant woman's circulation, therefore preventing the formation of anti-D antibodies. Because the risk of harm in future pregnancy is so substantial, while the risk of anti-D immunoglobulin administration is minimal, all women who are Rh negative are not previously alloimmunized, that is, no elevated antibody titers, must receive anti-D immunization following any potential sensitization event. Okay, yes, okay. It is cervical insufficiency. This patient has a cervical insufficiency, structural weakness of the cervix that predispose to the second trimester pregnancy loss. It is diagnosed by any one of the following criteria: painless cervical dilatation to the current pregnancy, a second trimester cervical length less than 2.5 cm, plus a prior preterm delivery, ultrasound based or two or more than two prior consecutive painless second trimester losses. Two or more than second trimester losses, which typically present with mild symptoms, uh, vaginal discharge, light spotting, followed by precipitous delivery. Because of the high risk recurrence, patients with history-based cervical insufficiency and treated with prophylactic circulation and a procedure in which a suture is placed to reinforce and add the tensile strength to the cervix. Prophylactic circulation is performed in the first trimester, 12 to 14 weeks of gestation, in which in patient with a history of cervical insufficiency, because it can recur in the second trimester, the suture is removed at term to allow vaginal delivery. Yes, fetal fibronectin, FFN, an extracellular matrix protein located between the maternal decidua and fetal chorion, is secreted whenever his interference is disrupted. Therefore, in patients with preterm contraction between 22 to 35 weeks of gestation, preterm contraction between 22 to 35 weeks of gestation, fetal, fetal fibronectin testing helps distinguish between preterm and false labor. However, FFN testing is not used in patients who are asymptomatic or at less than 22 weeks of gestation, as in this patient, because of high rate of false positive result. Okay, your wish. Okay, we can do tomorrow. Okay, okay. Yes.